Which of the following patients is the best candidate for a preoperative stress imaging test prior to non-cardiac surgery? A sedentary 65-year-old man with insulin-dependent type 2 diabetes, hypertension, prior TIA, scheduled for an iliofemoral artery bypass, has claudication. An 88-year-old woman with type 2 diabetes, hypertension, osteoarthritis, creatinine of 1.5, scheduled for a carotid endarterectomy, uses a walker for mobility and has no symptoms. A 72-year-old man with prior MI, insulin-dependent type 2 diabetes, scheduled for a left THA. He still swims 1 mile 4 days a week without symptoms. A 68-year-old asymptomatic woman scheduled for a AAA repair, former smoker, walks 18 holes of golf once a week, helps her husband rake leaves and tend their garden. Which of these patients should have a preoperative stress imaging test prior to non-cardiac surgery? Okay, next one. 74-year-old woman presents with symptomatic cholelithiasis due to an impacted stone at the gallbladder neck, requiring a laparoscopic open cholecystectomy. She climbs 2 flights of stairs without impairment, has no cardiopulmonary symptoms. You actually examine her, which is good, Mike. I like that. She's got a 3/6 harsh systolic ejection murmur on examination, so then you get your echocardiogram, which shows a mean gradient of 45 millimeter of mercury and a valve area of 0.9. The ejection fraction 60%. What's the appropriate next step? Proceed with cholecystectomy with close perioperative and hemodynamic monitoring. Delay cholecystectomy, perform aortic valve replacement. Delay cholecystectomy, perform transcatheter aortic valve replacement, perform a balloon aortic valvuloplasty followed by cholecystectomy, or perform an exercise echocardiogram. All right. 85-year-old woman scheduled for a left THA, permanent atrial fibrillation on warfarin, treated hypertension, no prior stroke, thromboembolism, or heart failure. She received bridging anticoagulation prior to her first THA and tolerated it well. By bridging, probably gave her low molecular weight heparin while the INR becomes subtherapeutic. INR now is 2.5. Creatinine is 0.7. What is the appropriate approach to preoperative anticoagulation? Continue the warfarin, titrate to INR 1.5, stop the warfarin 5 days prior, stop the warfarin 5 days, start low molecular weight heparin when INR is less than 2, stop the warfarin 7 days, start the low molecular weight heparin when INR is less than 2. Okay, so you can tell from the questions here that this is a very practical overview of the management of the patient with cardiac disease prior to non-cardiac surgery. We had gone back and forth on this topic and had omitted it entirely and then realized we can't omit this type of important information. Tried to then go to an online session, but realized that it was so important that the last couple years we've gone to a formal talk. And Dr. Mike Cullen, who you met earlier yesterday, one of our 3 amigos who does all the work for the board review course, has put together a very nice overview on how to manage these patients with cardiac disease prior to non-cardiac surgery. Michael?
All right. Well, thank you, Dr. Nishimura, and thank you, Dr. Aman. It is a pleasure to be here speaking with you about cardiac disease prior to non-cardiac surgery. I have no financial disclosures to report. We have 3 learning objectives this morning. The first is to be able to identify and manage patients with known or suspected coronary artery disease or other cardiac diseases who are at risk of cardiac complications during non-cardiac surgery. The second is to identify appropriate non-invasive tests in patients with known or suspected coronary artery disease at risk of cardiac complications during non-cardiac surgery. And the third is to select and adjust perioperative medical therapies to reduce the risk of cardiac complications during and after non-cardiac surgery, including anticoagulating agents. We are going to approach those learning objectives with the following outline. We will start by focusing on risk assessment of patients going for non-cardiac surgery. We'll then move to a discussion of non-invasive testing. We will talk a bit about non-ischemic heart disease, and then we will close with a discussion of perioperative medical therapy. Throughout the talk, when you see a green box, that's a Class 1 recommendation. When you see a yellow box, that's a Class 2A recommendation. When you see an orange box, it's a Class 2B recommendation. And when you see a red box, it's a Class 3 recommendation. Let's start with our discussion of risk assessment. When you are assessing a patient's cardiac risk prior to non-cardiac surgery, the guidelines recommend a stepwise approach. And we've outlined 5 questions here that you want to ask yourself. Question number 1, does the patient need emergent surgery? If the answer to that is yes, you are done. Stop, send the patient to the operating room, they need to have their emergent surgery. If the answer to that question is no, then you need to ask, is the patient having an acute coronary syndrome in front of me? If the answer to that is yes, treat the acute coronary syndrome. We're going to learn all about that this afternoon. More often than not, the answer to these first 2 questions is no, and then the guidelines say that we should calculate a patient's combined clinical and surgical risk. How should you do that? Well, the guidelines recommend using any number of calculators which are available. The links that I've provided here come from the NISQIP database. Unfortunately, you won't be able to Google calculators during the exam, at least this year. Now, maybe when the ABIM evolves and we can do these exams in our office, things are going to change. But for now, you can't Google the risk calculators. You can do these in your office. It works great when you're seeing patients. For the purposes of boards, though, you should understand some key clinical risk factors that are associated with perioperative cardiac risk. And the particular risk factors come from the old Revised Cardiac Index, or RCIR, criteria. Those 5 clinical criteria are: number 1, history of coronary disease; number 2, congestive heart failure; number 3, creatinine over 2; number 4, prior stroke or TIA; and number 5, insulin-dependent diabetes mellitus. If a patient has 2 or more predictors, they are considered elevated risk going into their non-cardiac surgery. Then we have surgical risk factors. So what I just talked about was a patient's clinical risk. In terms of surgical risk factors, this is data from over 10 million hospitalizations. It was published last year. Patients undergoing non-cardiac surgery, and the surgeries with the highest rates of cardiac events, over 5% rate of perioperative cardiac complications, included vascular surgery, thoracic surgery, and transplants. So those are what you should consider in this day and age high-risk operations. This paradigm comes from the European Society of Cardiology guidelines, and I put this here largely for reference, but I do want to highlight a few particular low-risk operations that may not be readily apparent. So breast operations, eye operations, and asymptomatic carotid operations are all going to be considered low risk with a less than 1% chance of perioperative cardiac complications. So we've calculated our patient's combined clinical and surgical risk. If both the clinical risk and the surgical risk are low, patient has a less than 1% chance of perioperative complications, you send them to the operating room. If they have an intermediate or high combined clinical and surgical risk, then you need to evaluate their functional status. You can begin your evaluation of functional status by asking 3 specific questions. Number 1, can you climb 2 flights of stairs? Number 2, can you walk 4 blocks on level ground? And number 3, can you rake leaves or push a lawnmower? And if the answer to any of those questions is yes, then the patient can probably do more than 4 METs of activity. If the answer to those questions is no, then they probably can't perform 4 METs of activity. We can look at it in a little bit more granular detail with this paradigm. So if the patient can perform basic activities of daily living, they're probably doing about 1 or 2 METs. If they can walk around their house, that's 2 or 3 METs. Again, walking a few blocks on level ground is closer to 4 METs. Climbing up 2 flights of stairs, walking up a hill, it's going to be 4 to 5 METs. Sexual intercourse, about 5 METs. And then heavier housework, scrubbing floors, lifting or moving heavy furniture, 6, 7 METs. And then certain more strenuous activities are going to be 8, 9, even 10 METs. If a patient can swim, play singles tennis, ski, either downhill or water ski, or play basketball, they can probably perform 10 METs of activity. Those patients have a very good functional capacity. So after we estimate a patient's functional status, we can say, well, if they can perform 10 METs, class 2A recommendation, send them to the operating room without any further testing. If they're in the 4 to 10 MET range, class 2B recommendation, they probably still could go to the operating room without further testing. But if you're concerned, or they have low functional capacity, or you just can't assess their functional capacity due to some other limitation, then you have to ask yourself, will further testing impact decision-making or perioperative care? And when I was going through and developing this talk and learning about this as a resident and fellow, I would always sort of, struggled with what that actually meant. Essentially, you have to ask yourself, if I get a stress test in this patient, is it going to impact the need for surgery, the timing of surgery, or any medications I use around the time of the operation? And if the answer to those questions is no, send the patient to the operating room. If the answer to those questions is yes, then you can consider a pharmacological stress test. So that is a brief overview of the risk assessment in patients going for non-cardiac surgery, and it offers a nice segue into a discussion of non-invasive testing. Let's take a step back and think for a moment. What causes perioperative cardiac events? When patients go to the operating room for non-cardiac surgery, they experience a lot of catecholamine surges. They have vascular injury, which creates a prothrombotic milieu. They lose blood, causes volume shifts. That may precipitate coronary plaque destabilization, and all of this is going to occur in the setting of baseline fixed coronary artery stenoses. Now, preoperative stress testing is only really going to pick up this factor. So it's not looking at all of the other things that could contribute to perioperative events. That being said, there is a very robust literature about the prognostic and diagnostic capabilities of preoperative stress testing. And this slide is my attempt to summarize the decades of literature on preoperative cardiac stress testing. So first point, preoperative stress testing has a high negative predictive value. If a patient has a negative preoperative stress test, they have a very low likelihood of having a postoperative event. Secondly, it has a low positive predictive value, so even an abnormal stress test doesn't mean the patient is going to have a postoperative event. Number 3, resting abnormalities matter. So that resting wall motion abnormality on your stress echo or that baseline perfusion defect on your regadenoson system IBI scan, that has adverse prognostic implications independent of any ischemia. That being said, if a patient has ischemia, it matters, and the more ischemia a patient has, the higher the risk for postoperative events. And then finally, the higher the risk patient, the increased the accuracy of the test. So these tests perform better in higher risk patients. So what do the guidelines say? Well, the American guidelines say that pharmacological stress testing should be avoided in patients at low risk for non-cardiac surgery. We certainly don't want to do it routinely. And they say it's reasonable to do class 2A recommendation in patients at elevated risk with poor functional capacity if it will change management. In terms of exercise testing, they say that you should forego exercise testing in patients with elevated risk and excellent functional capacity. You should avoid using exercise testing routinely in low-risk patients. And then they stipulate a number of class 2B recommendations. They say you can consider functional testing in patients with elevated risk and unknown functional capacity. You can forego exercise testing in patients with elevated risk and moderate or good functional capacity. And you can consider exercise imaging stress tests in higher-risk patients with poor or unknown functional capacity. Got it? Okay. When I saw this, I was confused, okay? Anyone else confused? And so what did I do? I said, okay, what else is out there? So let's get in our telescope and look east to the European guidelines. And the European guidelines, I think, which were published the same year as the American guidelines, outlined a very nice structure for making determinations about whether or not a patient needs a preoperative stress test. So they give a class 1 indication to preoperative stress testing in patients with all of these 3 factors. So number 1, patients undergoing high-risk surgery. Number 2, patients with multiple clinical risk factors like we talked about with our RCRI score. And number 3, patients with poor functional capacity. So I think it is very reasonable, both for the purposes of board exams and your practice, that if a patient has these 3 characteristics, you have a good reason to do a preoperative stress test. The European guidelines also say that you could consider non-invasive testing prior to intermediate or high-risk surgery if the patient had a low functional capacity and only 1 or 2 clinical risk factors, and similar to the American guidelines, we should avoid doing it prior to low-risk surgery. Okay, that's nice. Now we know when to get the preoperative stress test. What do you do if it's positive? Okay, now we're stuck. Don't make it that complicated. You want to treat a positive stress test in the preoperative setting like you would any other positive stress test. Dr. Prasad just outlined the high-risk characteristics that merit coronary angiography. That's the same approach you want to take in the preoperative setting. What about other preoperative tests? Electrocardiogram. Avoid doing it routinely, particularly in low-risk asymptomatic patients. It's reasonable to get an ECG in patients with known heart disease unless they're undergoing low-risk surgery. You can consider doing it in asymptomatic patients, again, unless they're undergoing low-risk surgery. In terms of resting left ventricular function assessment, typically with an echocardiogram, again, avoid doing it routinely. Reasonable to do in patients with heart failure, particularly if their clinical status is changing. Reasonable to do in patients with undiagnosed dyspnea. And if a patient has a history of left ventricular dysfunction, but it's been a year since you've assessed their left ventricular function, even if they're clinically stable, you could still consider doing another resting left ventricular function assessment. In terms of cardiopulmonary exercise testing, the guidelines will give a Class 2B recommendation to cardiopulmonary exercise testing in patients undergoing elevated risk procedures. I find this to be particularly helpful if you're really trying to sort out a patient's functional status. So I would certainly feel comfortable using cardiopulmonary exercise testing in that particular situation. Cardiac biomarkers. This can be a confusing issue. Guidelines don't make a very strong recommendation. They say you can consider assessing troponins in high-risk patients before and up to 2 to 3 days after major surgery, but any abnormalities in that have to be taken in consideration in the context of the entire clinical picture. You don't want to jump on isolated troponin elevations without actually thoroughly evaluating the patient and figuring out what is going on. The guidelines don't really give any established role for natriuretic peptides or other biomarkers in the perioperative evaluation. I don't think that would show up on board exams. Who needs a preoperative angiogram? Relatively simple. Same as non-preoperative patients. Dr. Prasad just spoke about this. So patients with unstable symptoms, patients with a high-risk stress test, patients with concern for severe coronary disease with or without left ventricular dysfunction. Those are the patients where you are going to be considering a preoperative coronary angiogram. And then if they go to the cath lab, who needs to be revascularized? Okay? If you're going to revascularize them independent of the operation, you revascularize them in the preoperative setting. So if the revascularization is indicated according to other guidelines, which we've learned about this morning and we're going to learn more about this afternoon, okay, then you revascularize them. But you should avoid performing routine coronary revascularization exclusively to reduce perioperative risks. Trials have shown that that is not beneficial. There is no role for, let's put a stent in to get the patient through their operation. Okay? If they need a stent, they need a stent. Don't do it just to get them through their operation. Bottom line on non-invasive testing, I've covered a lot of material. Okay? So you're going to obtain your imaging stress test. This is your dobutamine stress echocardiogram or your regadenoson system scan, most commonly in patients with multiple risk factors undergoing high-risk surgery and a poor or unknown functional capacity if the results of the stress test will change management. You want to obtain your electrocardiogram, your resting echo, cardiopulmonary exercise test, and or coronary angiogram if you otherwise would do so largely independent of the non-cardiac surgery. So don't get too hung up on these tests. If the patient needs an ECG, they need an ECG whether or not they're going to the operating room. So now we can recap our algorithm on risk assessment now that we've talked about all the different iterations and non-invasive tests. So remember, step 1, patient needs emergent surgery, they go to the operating room. Okay? Step 2, patient's having an acute coronary syndrome, you want to treat the acute coronary syndrome according to your ACS guidelines. Step 3, calculate their risk. If they're low risk, they go to the operating room. If they're intermediate to high risk, assess their functional status. If their functional status is good, go to the operating room. If their functional status is poor, consider non-invasive testing if it will change management. Okay? That is your risk assessment in a nutshell. Okay? That's my joke for the day. Sorry, that's as good as it gets. Okay. So we've talked about risk assessment. We've talked about non-invasive testing. Let's move next to a discussion of non-ischemic heart disease. When I was putting this talk together, I dug through the archives and found this paper from the New England Journal of Medicine published in October of 1977. How many people remember what they were doing in October of 1977 besides Nishimura? How many people were born in October of 1977? So this paper was published by a group in Boston. They tried one of the first studies to develop a multifactorial index of cardiac risk in patients undergoing non-cardiac surgery procedures. And this study reported severe aortic stenosis carried a 13% perioperative mortality rate, 13% perioperative mortality. And that number really struck fear into the hearts of cardiologists, surgeons, anesthesiologists, people taking care of these patients in the preoperative setting. And for a number of years, we were really scared to take anyone with significant valve disease to the operating room for non-cardiac surgery. Now, over the years and decades, surgical techniques improved, anesthesia techniques improved. We developed a better understanding of how to handle these patients. This study actually came out of Mayo Clinic about almost 30 years ago, looking at 48 patients with aortic stenosis undergoing non-cardiac surgery. These patients had a mean valve area of 0.6 centimeters squared. Now, I know we haven't had our valve talks yet, but that's pretty severe aortic stenosis. How many of you see patients with a valve area of 0.6 centimeters squared in aortic stenosis nowadays? That doesn't happen very often. Still, though, these patients had no intraoperative deaths with very close hemodynamic monitoring. Okay? So over the years, and other studies like this have been published, over the years we've come to realize that yes, severe aortic stenosis will increase risk, but outcomes have improved, and oftentimes we can get these patients through their non-cardiac surgery. So what do the guidelines say? Okay. Guidelines say that elective non-cardiac surgery with appropriate intraoperative and hemodynamic monitoring is reasonable to perform in patients with asymptomatic severe aortic stenosis. And you can consider performing elective non-cardiac surgery in patients with asymptomatic severe mitral stenosis if you can't balloon their valve. We're going to learn more about when you need to balloon the valve later on this week, but for the purpose of this talk, if you can't balloon their valve, you can still potentially take them to the operating room. In terms of regurgitant lesions, they are often better tolerated than stenotic lesions. Okay, the patients don't have the afterload demands on the ventricle that they see in stenotic lesions, particularly aortic stenosis. The key with patients with regurgitant valve disease when they go to the operating room is to maintain their preload. Don't want to dry them out because they're used to that ventricle being big, and avoid excessive afterload that could adversely impact their cardiac function and mechanics. Okay? So the guidelines will say that in patients with severe regurgitant valve disease, so asymptomatic severe aortic stenosis and aortic regurgitation, elective non-cardiac surgery is reasonable, particularly if the left ventricular ejection fraction is normal. Okay, so you can often get these patients through their non-cardiac surgery as well. Cardiac arrhythmias, if the patient has any unstable arrhythmias before elective non-cardiac operations, you want to deal with that. You want to obviously look for reversible causes in the perioperative setting, respiratory abnormalities, electrolyte abnormalities. And if a patient is on an antiarrhythmic medication, you want to continue that throughout the perioperative period. In terms of heart failure, patients should be on guideline-directed heart failure before they go to their elective non-cardiac surgery. You want to optimize their heart failure meds as much as possible. If the heart failure is newly diagnosed, you want to work it up, get them on meds, figure out what's going on before they undergo any elective operations. If they're on a beta blocker, you want to continue that throughout the perioperative period. If they're on an ACE or an ARB, you may hold that the day of the operation. If they're at risk of becoming hypotensive, then you want to resume it as soon as possible afterwards. So that is a nice segue into our last section on perioperative medical therapy. We're going to focus on a number of different classes of medications. We're going to start with the beta blockers. We'll talk briefly about statins. We'll talk about antiplatelet therapy, anticoagulant therapy, and then finally a few other miscellaneous classes of medications. Use of beta blockers in the preoperative setting is a long story. I'm going to try to simplify it here a little bit. This is a study published in the New England Journal of Medicine in 1999 looking at 112 patients undergoing major vascular surgery who had an abnormal dobutamine stress echocardiogram. These patients were randomized to bisoprolol, started 1 week before the operation, versus standard care. Followed for about 1 month to an outcome of death or non-fatal myocardial infarction, and you can see here pretty phenomenal separation in event rates. So patients with standard care had a 34% rate of postoperative death through non-fatal myocardial infarction. Patients who received bisoprolol had a 3.4% outcome death and non-fatal myocardial infarction, for an order of magnitude difference in event rates. Okay? Now, this created initially a lot of excitement about the use of beta blockers in the perioperative setting, and then along came the POISE trial. And what the POISE trial thought was, okay, maybe we can just give the patients high-dose beta blockers on the way to the operating room. Maybe that will help us reduce the risk of perioperative cardiac events. And so the POISE trial randomized over 8,000 patients to metoprolol succinate 100 milligrams 2 to 4 hours before their operation compared to placebo. And you can see here that in the POISE trial, patients who received metoprolol in the orange blocks here had a lower absolute rate of non-fatal myocardial infarction. However, higher rate of stroke with metoprolol, higher rate of significant hypotension with metoprolol, and a higher overall total mortality. So giving the beta blocker actually increased mortality. And so this had a significant influence on the guidelines, and the most recent iteration of the guidelines now say that if a patient is on a beta blocker, you want to keep them on their beta blocker as they go through the operation. They've proven that they can tolerate that dose of beta blocker, keep them on it throughout the perioperative period. If they are not on a beta blocker and they are high risk, you can consider starting a beta blocker provided you have ample time to assess safety and tolerability. And this isn't 2 or 3 days. This is at least 1, ideally 2, potentially even longer weeks. Okay? So you need time to make sure they can tolerate the beta blocker before sending them to the operating room, because you don't want them to get hypotensive or have other complications. As we saw in the POISE trial, that can have adverse prognostic consequences. And then finally, guidelines say class 3, do not start beta blockers the day of surgery. Do not give someone slug of beta blockers or even oral beta blockers. If they're naive to beta blockers the day of their operation, you can precipitate hypotension and other significant consequences. Statins, it's a little bit easier. Okay? If a patient is taking a statin chronically, you want to continue that statin throughout the perioperative period. The guidelines also note that preoperative initiation of statins is reasonable in patients undergoing vascular surgery. That's pretty straightforward. Most patients with undergoing vascular surgery have arterial disease. They should probably be on a statin anyway if they are not already. In terms of antiplatelets, okay, how many of you have gotten a question in the last month from a colleague or a consult about Plavix in a patient going to the operating room? Okay? That's probably more than half of the people in this room. It comes up all the time, okay? But it is not as complicated as you might think. And Dr. Prasad outlined nicely a lot of the reasons why this is less of an issue nowadays. So coronary stents are getting better. Our risk of stent thrombosis is decreasing. The use of bare metal stents is decreasing. We're not really putting in as many bare metal stents anymore. And low-dose aspirin is becoming more and more accepted. So rather than have to try to figure out what dose of aspirin to give, most people nowadays are just on aspirin 81 milligrams a day. And so the guidelines are pretty clear about when you can hold P2Y12 inhibitors or Plavix, clopidogrel, after PCI for non-cardiac surgery. So in a patient that's had a bare metal stent, okay, you wait 30 days, and then class 1 recommendation, you can hold the P2Y12 inhibitor and then send them to the operating room. In patient who has had a non-first generation drug-eluting stent, so not the Cypher, not the Taxa stent, but pretty much all of the stents that we're putting in nowadays are not first generation stents, okay? 3 to 6 months, Class 2B recommendation, you can hold the P2Y12 inhibitor. After 6 months, you're golden, okay? You can hold the P2Y12 inhibitor and then send them to the operating room. Okay? Avoid holding the P2Y12 inhibitor less than 30 days after a bare metal stent or less than 3 months after a drug-eluting stent. Okay? And then you want to continue their aspirin, and then you want to resume the P2Y12 inhibitor as soon as you can afterwards, and then complete the duration of therapy that you had decided upon. A few caveats about antiplatelets in this situation. If a patient needs to go emergently to the operating room early after PCI, within 30 days after a bare metal stent or 3 months after a drug-eluting stent, you continue the dual antiplatelet therapy. Okay? You don't want to precipitate stent thrombosis. You continue the dual antiplatelet therapy. Okay? The use of aspirin in non-stented patients, what do you do in that situation? It's really going to depend on the balance of the bleeding versus the ischemic risk. Okay? That has to be an individualized decision. The guidelines don't offer any clear recommendations, and I doubt it would show up on board exams. Final section. To bridge or not to bridge. Okay, we're going to talk briefly now about preoperative anticoagulation. And I should note that most of the discussion here is going to be about anticoagulation for patients with atrial fibrillation or other indications for anticoagulation. You're going to hear from Dr. Gasky on Tuesday about bridging anticoagulation in the setting of patients with prosthetic heart valves. Don't worry, Jeff, I will not steal your thunder. If a patient comes to you with a question of bridging anticoagulation or how to manage preoperative anticoagulation, you want to ask 4 questions. First of all, is the initial indication for long-term anticoagulation appropriate? Okay? Do they need to be on their anticoagulation long-term? Sometimes the answer to that is no, and it makes your job really easy, right? Stop the anticoagulation, go to the operating room, you don't need to start it afterwards. Okay? Next question, can you do the procedure on anticoagulation? If the answer to that is yes, then your job becomes a lot easier as well. More often than not, though, we have to make a decision about when to hold anticoagulation. And then if you hold anticoagulation, do you need to bridge them, or do you need to cover that? Do you need to give them therapeutic levels of a short-acting anticoagulant to make sure that the patient is subtherapeutically anticoagulated for as brief a period of time as possible? We'll talk first about question number 3. So when do you hold anticoagulation? If a patient is on warfarin, you check their INR about 1 week before the operation. If their INR is 2 to 3, you stop warfarin about 5 days before the procedure. If their INR is less than 2, you stop warfarin 3 to 4 days before the procedure. And if the INR is greater than 3, stop warfarin 5 or more days before the procedure. You're probably going to need to recheck it again in that interval time. If a patient is on a direct oral anticoagulant, it's a little bit more complicated. It's going to depend on a number of factors: what particular DOAC they're taking, their renal function, and the bleeding risk of the procedure. It's beyond the scope of this talk to go into all of the different scenarios. I do provide a reference here that gives recommended durations for withholding DOACs in the preoperative setting. This is a consensus decision pathway that was published in JACC last year. It outlines all of the different scenarios depending on the specific drug and the bleeding risk of the procedure and the patient's renal function and all that. It's a useful reference to keep handy. Important to note that bridging is rarely necessary in patients with DOACs due to their shorter half-life. Okay? The half-life of the DOACs is not that much different from low molecular weight heparin, so you don't really gain a lot of benefit by putting them on low molecular weight heparin and holding the DOAC. So you rarely need to bridge the patient. I'm going to make one specific comment about neuroaxial procedures. These are things like vertebroplasties, epidural steroid injections, kyphoplasties, procedures occurring in high-value real estate where you really, really need to make sure that the patient doesn't bleed, because if they bleed, it could have catastrophic consequences. Okay, if they're on dabigatran, you hold the dabigatran 4 to 5 days before their operation. If they're on apixaban or rivaroxaban, hold it 3 to 5 days before their operation. If they're on warfarin, follow the same guidelines that we recommended earlier, but really make sure that they're not still anticoagulated when it's time for the procedure. So, you've made a decision when to hold the anticoagulation. Next step is, do they need to be covered with a shorter acting anticoagulant, most commonly low molecular weight heparin, while they are subtherapeutically anticoagulated with their chronic anticoagulant? And you're going to base that decision in part on their CHADS-2 VAS score. So if the CHADS-2 VAS score is low, less than 4, and they've had no prior stroke or TIA, no bridging necessary. If the CHADS-2 VAS score is greater than or equal to 7, so high, and they've had a recent stroke or TIA in the last 3 months, then you use bridging. If a patient falls into an intermediate range where their CHADS-2 VAS score is 5 to 6, or they've had a remote stroke or TIA, something over 3 months ago, then you have to assess the patient-specific bleeding risk going into the operation. How do we assess patient-specific bleeding risk? The consensus statement that I talked about outlined 4 factors associated with increased bleeding risk. So if a patient's had a major bleed in the last 3 months, if they've had an intracranial hemorrhage in the last 3 months, if they have a platelet abnormality or have to remain on aspirin, or if they've had prior bleeding during previous episodes of bridging, any one of these factors is going to be associated with a higher bleeding risk around the time of the operation. So if a patient has one of those factors, their bleeding risk is up, you don't use bridging. If a patient does not have one of those factors, their bleeding risk is low, and then you can use bridging. In terms of when to resume the anticoagulation, if they're on warfarin, you want to restart it the day of the operation. Once you achieve hemostasis, you can start your low molecular weight heparin. So if there's low bleeding risk, and this you have to determine this based on a discussion with their surgeon. If they're low bleeding risk, you can resume the low molecular weight heparin 24 hours after their operation. If they're high bleeding risk, it's going to be 48 to 72 hours after their operation. If they're on a DOAC, the timing of DOAC resumption is going to be similar to the low molecular weight heparin. Important to note that in the trials and in practice, we've seen that resuming anticoagulation too early is associated with an increased bleeding risk. So you got to be really careful about resuming anticoagulation too early. The risk of any thrombotic lesions happening in this time is usually quite low. So be careful about resuming the anticoagulation too early. One quick slide on other perioperative medications before we wrap up. So if there's a question about clonidine, the patient is taking clonidine, you can continue clonidine, but do not start clonidine in the preoperative setting. ACEs and ARBs, as I mentioned with heart failure, you can continue or hold them depending on a patient's risk for hypotension. If you do hold it because the patient is at risk for hypotension, get the patient back on it as soon as possible afterwards. Calcium channel blockers, there's no good data to recommend their regular use. As you would in other heart failure patients, you want to avoid diltiazem or verapamil. Let's recap preoperative medical therapy. Remember beta blockers. If you're going to initiate them in high-risk patients, start low, go slow, give the patient time to demonstrate that they tolerate it. Avoid high-dose beta blockers, initiating them shortly before an operation. Statins, use preoperatively as you would in non-preoperative settings. Remember, with your P2Y12 inhibitors, you can hold them 30 days after a bare metal stent, 6 months after a drug-eluting stent. You're going to want to indicate, whoops, what's going on there? You are going to okay, there we go. So you are going to want to limit bridging to situations where the thrombosis risk is going to significantly exceed the bleeding risk. You want to avoid initiating clonidine preoperatively. You can hold your ACEs and ARBs, but you want to resume them as soon as possible afterwards. So we've covered a lot of material. We've talked about risk assessment, non-invasive testing, non-ischemic heart disease, and perioperative medical therapy. I'm going to close with 4 pearls for the boards. So first of all, non-invasive imaging stress tests are indicated in patients with multiple risk factors, high-risk surgery, poor or unknown functional capacity if it will change management. That's when you do your preoperative stress test. Number 2, patients with severe asymptomatic valve disease can undergo elective non-cardiac surgery with close hemodynamic monitoring. Number 3, avoid initiating high-dose beta blockers shortly before non-cardiac procedures. And number 4, limit the use of bridging anticoagulation to patients where the thrombotic risk will significantly exceed the bleeding risk. With that, I would like to thank you for your time. We'll go over the questions now.
Very nicely done, Michael.
Thank you.
A lot of information there, a lot of actually useful practical information too. It'll help you, I can tell you this. So let's go to this first slide. Which patient should you get a preoperative stress imaging test? 65-year-old man with risk factors, has an iliofemoral bypass, claudication, but no other symptoms. An 88-year-old woman with risk factors, carotid endarterectomy, uses a walker. 72-year-old man with prior MI and insulin-dependent diabetes for a hip. He swims a mile a day. A 68-year-old woman, asymptomatic, scheduled for a AAA repair. Some risk factors, but walks 18 holes of golf once a week. Which of these should you do a preoperative stress test?
97. I think that's a round of applause.
That's it.
Yeah, so that A is the guy. He's high-risk surgery, poor functional capacity, multiple risk factors. He's the type of patient where you would consider doing that.
Now, you had a number of people who are in the situation like us that you get the transplant surgeons prior to a liver or a kidney transplant, and they insist that you do stress tests on them all the time. What's your thought on prior, this evaluation prior to liver or kidney transplant?
You know, they are going to be higher risk. I think the thought on that from the side of the transplants, you don't want to put an organ, someone else's organ, in an organ that could go to a healthier patient if the patient has significant cardiac disease. So they want to make sure that they don't miss anything. That being said, these patients, you know, oftentimes these stress tests come through and they're quite normal, which is helpful. If it's abnormal, though, I think you have to take it with a grain of salt. You don't want to necessarily get too excited, because especially for mild abnormalities, that shouldn't necessarily preclude the patient from being, from continuing their transplant evaluation. You can't get too excited about a minor abnormality on a stress test.
Yeah, I think so. There's arguments all the time with these with the surgeons like this, but I think that Michael's point about you're going to treat coronary disease as you would without upcoming non-cardiac surgery. So if they're a patient who has 3-vessel disease that would benefit from revascularization in terms of prolongation of life, you go ahead with it. But if you have a patient that you wouldn't ordinarily do an intervention on, you hold the surgeons back and you say, listen, you go ahead with your transplant evaluation because we are not going to do anything to pull them through the operation.
Right, exactly.
So I think that's something very important to understand and to make your surgeons understand. Okay, a 74-year-old woman presents with symptomatic cholelithiasis due to an impacted stone at the gallbladder neck. She'll require at least a lap and maybe an open. She climbs 2 flights of stairs, no problem. 3/6 systolic ejection murmur on exam. Echo shows a mean gradient of 45 with a valve area of 0.9 centimeters squared. EF is 60%. What's the next appropriate step? Proceed with close monitoring, delay and perform aortic valve replacement, delay and perform TAVR, delay and perform valvuloplasty, or do an exercise echocardiogram.
Two for two.
Okay, now there were some questions. What does close monitoring mean?
So it's going to involve an anesthesiologist that is familiar with these situations. It may involve measurement of intraoperative hemodynamics with the Swan-Ganz catheter. It's going to involve very close attention, make sure they don't get too hypotensive or too hypotensive because it can getting these patients back from major swings in hemodynamics can be very difficult. So you need a team that's experienced in this situation that can help you get the patient through the operation.
Now, have you ever told an anesthesiologist to keep the heart rate and blood pressure stable?
Yeah.
So that's the thing they hate the most. But one thing you can help them with, though, is that these patients with aortic stenosis are going to get in trouble mainly with hypotension, like Mike said. And if a person with AS gets hypotensive, this is in the cath lab too, they're going to have this death spiral where they get hypotensive, they can't perfuse, their coronary flow goes down, they've got LVH, they're going to get ischemic, they're going to get more hypotensive, and this is vicious cycle. And the way you do it is like we were talking about last night, you want to increase their afterload. So the patients with AS, if you talk to our really, really good anesthesiologists, they use a lot of phenylephrine on these people, and they just keep the blood pressure up as high as possible. So that's the type of conversation you can have with them rather than keep the heart rate and blood pressure stable and stuff. Now, with that being said, go back to this one, because there's been some other questions here is, what's wrong with operating on their aortic valve since you probably might do it anyway if they were not going to surgery in an asymptomatic severe AS?
Well, part of the issue is you don't want her to get a hot gallbladder around the time of her aortic valve. I mean, she's got this impacted stone at the gallbladder neck. So the last thing you want is in or shortly after an aortic valve, while she may potentially be tenuous, is to have her get this inflammatory state from this impacted stone.
And then get infected.
And then get infected or something like that, yeah.
Yeah. So you definitely want to hold off on any type of a valve intervention in the presence of some abnormality that the surgeon could correct that could cause you to be septic or whatever. But let's take it another step. Let's say she's going for a hip or a shoulder, which wouldn't be at risk for infection.
So if it's elective, then I would say that, we would, if she's asymptomatic, the guidelines would say class 2A, elective non-cardiac, you could hold it, okay? So you could do the hip or the valve, you could do the hip or the knee first.
Yep.
Class 2A recommendation.
Yep. And I think that's very reasonable, but but on the other hand, and I'm saying this out of the guidelines.
Yeah.
Surgeons now with TAVR, your risk of an aortic valve replacement should be less than 1%.
Yeah.
And if you've got severe aortic stenosis, we'll go over this on Tuesday, but if you've got severe aortic stenosis and you have other things like you know that the aortic stenosis has progressed, that they're otherwise a very healthy person, it's not unreasonable to consider operation on the asymptomatic severe aortic stenosis after a discussion with the patient, knowing that there's probably about a 50% chance that they'll need something done in the next 2 to 3 years. So if you have that discussion and you kind of take the non-cardiac surgery out of the equation and they would say, yeah, let's go ahead with the valve operation, it's not unreasonable to do that first before non-cardiac surgery. So that's just kind of to let you know we're getting, and as we talk about Tuesday, we're getting more and more aggressive with lower thresholds for operation because our operations and transcatheter surgeries are getting much better now with a lower risk, so we're lowering our threshold. With that being said, I agree with Mike now, especially if you're asked, we should send this patient for the non-cardiac surgery because there's a good chance they'll get through it, but something to think about in the future. If your risk of operation is low in asymptomatic severe AS, you know they're going to need an operation anyway, it might not be unreasonable to go ahead.
Right. I suspect in real life, oftentimes the patients would want their valve done first.
Yeah. But you're right about the cholecystectomy.
Yeah.
Because we've had problems post-operatively with gallbladders that start getting hot, the patient gets infected, and then you've got a problem. So anytime you've got a surgery that could be related to an infection, you always want to take care of that before valve surgery. Okay, last one. 85-year-old woman scheduled for a left THA, permanent atrial fibrillation on warfarin, treated hypertension with no prior stroke, thromboembolism, or heart failure, received bridging anticoagulation prior to her first THA and tolerated it well. INR is 2.5, creatinine's 0.7. What's the appropriate approach to preoperative anticoagulation? Continue warfarin, titrate to INR 1.5, stop warfarin 5 days prior, stop at 5 days prior, start low molecular weight heparin, stop at 7 days prior, start low molecular weight heparin.
Okay, 91%.
91, not 95, but any comments about the low molecular weight heparin?
Yeah, so even though she had bridging before, doesn't necessarily mean she needs it again. Okay, so she's 85. So if you look at her CHADS VASC score, she's got, you know, her age and gender are going to get her to 3, and then she's got hypertension, that'll get her to 4. It's still relatively low for these purposes, so that in and of itself means she doesn't need bridging.
Yeah, so probably either a CHADS score of 7 or more.
So yeah, so less than 4, they don't need it. 7 or more, you should probably do it. Or if they've had a recent stroke.
A recent thromboembolic
Yeah,
event.
exactly.
So I think that's a nice thing that he put together to remember about when you need to bridge. And when you bridge, the low molecular weight heparin is appropriate?
Yeah.
Okay. Now, there was a question about your antiplatelet agents.
P2R12, yeah.
Okay, in non-cardiac surgery. And there's this big thing about if you've got stable disease and you had a drug-eluting stent, it's 6 months. If you have an acute event like Nanda's going to talk about and you get a drug-eluting stent, you want at least 12 months. Now, stopping the antiplatelet agent before non-cardiac surgery, does it matter whether it's ischemic or non?
No. So what the discussion that you just outlined is the total duration.
Correct.
Is the total duration of dual antiplatelet therapy.
Correct.
For this purpose, it's when you could safely hold it for a brief period of time for a non-cardiac procedure.
Yeah. So it doesn't matter. So even though the duration is dependent upon whether it's put in for stable coronary disease or an acute coronary syndrome, as Michael said, being able to stop it for non-cardiac surgery is not dependent about the indication to put it in. Okay. And then there's a whole lot of questions here. They're saying their surgeons won't operate on low-dose aspirin. What do you tell them?
Well, first of all, why is the patient on low-dose aspirin?
Well, after a stent.
Oh, after.
So they get a stent, you're going to stop your clopidogrel,
Yeah.
and you're going to tell the surgeon to continue the aspirin, and if the surgeon says, I don't want him on aspirin, what are you going to say?
It's going to really be a balance. I would say probably they should probably be on the aspirin. We don't want any major issues happening here. I mean, I think if the surgeon is really, really concerned about bleeding, you can have a discussion with them, but generally, I would continue the aspirin.
Yeah, I would say, if you stop the aspirin, don't call me when your patient infarcts.
Right, yeah.
Because stopping that aspirin is the worst thing that you can do, even if they go to neurosurgery, and we've convinced our surgeons of that.